very much. Now I will request Dr. Zain Khatib to present his case of refraction. Zain.
Thank you for this opportunity. Can I have my presentation?
My pulsar.
Okay, so this is actually an interesting case. So this was a 45-year-old female who had slow progressive decrease of vision in the right eye since many years. Her left eye had nil vision. She had an old RD operated 5 years back. She had a history of LASIK done about 20 years back for a number of around -16 is what she said. And she had actually come for a second opinion. She had already been advised right eye cataract surgery elsewhere, and she was posted for surgery in the coming days. So when we examined her, her vision in the right eye with her current glasses was around 6/60 with a prescription of -4.5, and she improved to around 6/18 with a -7 diopter sphere. Her cornea seemed clear. We couldn't make out any flap margins of the LASIK procedure. And her lens showed a small central nuclear sclerosis. I don't have the actual picture, but it was quite small central nuclear sclerosis. And her fundus was actually normal. She had a myopic degeneration, nothing to comment about. So my question to the panel is, what do I do? Do I go ahead with the cataract surgery or get some more investigations done?
So I think the first important thing is that you need to get a pentacam done. But this is a clear-cut case of a nuclear sclerosis where you keep on increasing the myopic correction and the patient tends to improve. You tend to get nuclear sclerosis slightly earlier in patients who have undergone for high myopia LASIK procedure. So the only problem here would be the lens power calculation. So you should ideally look at the IOL Master 700, or you do a TrueNet K and you use the formula to get the power calculation. Apart from that, the patient will do pretty well. This is a clear cut. On the image, it is clearly showing it's nuclear sclerosis. So I don't have any confusion in getting this person again nearer to emetropia by doing a cataract surgery with a lens implant.
Right.
I think very rightly, such patient who 16 diopter myope and has undergone LASIK surgery, calculation of the IOL power is extremely difficult, challenging. Even we use ACRS, ECRS. There is a formula, all the parameter we have to fill and correct that what is the IOL power which comes, which should be implanted. There will be gross difference in just simple IOL power calculation and by doing it ECRS. You have to feel that. That is one. Second thing is we have to determine also that what is the outcome. For that, macular OCT is very, very important. Whether macula is saved, sometimes there may be a lot of degeneration, but macula is saved. So macular OCT in such patient, or almost we do in every case, macular OCT. So I think these two things should be done. Besides, I think already Dr. Saab has already said.
In the high myopia, the patient has been, LASIK has been done, and the cataract is there. We remove the clear lens for reducing the number. As there is a cataract, I think like Mahipal sir said, we should tackle it. Only thing is that, like Jagadram sir said, that the posterior pole, that is a macula, is very important, because in such number there may be some myopic degeneration like that, and accordingly you should give the guarded prognosis and you can go ahead, because the chances of RD are also going to increase after cataract surgery. Yes.
Right. So, I actually couldn't convince myself that the cataract was actually responsible for vision loss. Macular OCT was normal. And I always felt that why should I do surgery if the other eye had detachment, unless the patient really has, symptoms. But she convinced me that her vision was actually very poor, and we did a contrast sensitivity, and the contrast sensitivity actually shows that the vision was really very poor. And as sir said, we went ahead and did a pentacam. The pentacam is very interesting. It shows acute flattening in the central 3 millimeter. It's going to as low as 30, and the pachymetry is not so bad. It's around 512 in the thinnest, and only in the central part. So I assumed that this is olden time LASIK, where a very small optic zone was used with less tissue ablation. And if we just study the sagittal curvature in the center, we see centrally the curvature has become as low as 28 diopter. And if we run an aberration on this, it's a very high spherical aberration. So almost 1.42 microns spherical aberration, and up to 0.6 beyond is considered really bad. And these are some of the other corneal parameters showing poor point spread function and modulation transfer function. So I concluded that it was the highly aberrated cornea along with the lenticular changes and amblyopia which led to the poor quality of vision. And in this case, I didn't want to only tackle one of them. Amblyopia, of course, can't be treated, but I thought that I want to do a corneal surgery to improve the surface of the cornea along with the cataract surgery, and then go ahead. So I had decided that I'll do both. Now the point was whether I'll do a corneal surgery first or whether I'll do cataract surgery first. So if I would do cataract surgery, remove the cataract, and then go to tackle the cornea, maybe the patient would have been happy only after cataract. But if the patient would be unhappy, if I would do a corneal procedure later, it can lead to a very high refractive error because of the corneal flattening. So I thought first I'll do corneal procedure. I'll make the cornea better. I'll increase the optic zone, remove the aberrations by either LASIK or PRK, and then go ahead with cataract surgery. And I would do calculate the IOL power by using the Barrett Universal 2 ASCRS and ray tracing and all those points. So I even got an OCT done, so I couldn't make out a flap as such, and the epithelium was quite regular. So I decided to do a trans PRK with higher order ablation. And in this case, this is the profile. You can see it's a zone enlargement profile, so it would lead to a central, bump in the cornea. Post-operative day 7, the patient was around -18 because she had become more myopic because of the peripheral ablation, and this would come down. So post-op day 21, she was -16. Post-op day 40, she was -14. The epithelium and corneal surface had stabilized, and you can see the difference between pre-op and post-op pachymetry, how the zone has got enlarged quite well. And this is the change in pachymetry, which is quite similar to the ablation pattern that we had planned. And if you just see the front surface of the cornea, from that 28 diopter, we've made it to around 41, 42, which is a more physiological cornea. And if you look at the spherical aberration profile, it has come down very significantly. Even the total higher order aberration has come down significantly, and so has the modulation transfer function and point spread function. So here we repaired the cornea first, and then we decided to go ahead with cataract surgery. Cataract surgery, we decided to put a 3-piece spherical IOL so that it would be a good amount of spherical aberration. And in the IOL power calculation with a Barrett True K, we got plus 4.5 diopter. We also did ray tracing, which came to around 1.5 diopter. As far as toric lens, we decided not to do toric because we were anyways doing a 3-piece lens and there was not much astigmatism. Final power which we took was around 3, which was an average of most of the formulae. Post-operative 1 month, she's uncorrected 6/12, best corrected 6/9 partial, probably because of amblyopic and myopic degeneration. She's happy with wearing only reading glasses, and her contrast sensitivity also has considerably improved. Now, I don't know whether I did right by doing this and then cataract. Maybe only cataract would have helped, but I just realized that I always feel cataract may not be the answer to everything. I always assess the subjective visual quality by contrast sensitivity, and a stepwise calculative approach is needed for complicated cases.
So anyway, I think you got away with good results. See, the patient had a LASIK several years ago, right?
Yes.
And the patient was reasonably happy, and there is a definitive history. So the abrasion profile has obviously not changed between when the LASIK was done and now. I don't remember you having told, or maybe I was inattentive. I don't know how many years have passed between LASIK and
20
years. So the patient was happy for 15, 17 years at least, right? So I have never had a patient coming back and being unhappy with just a cataract surgery, because the nuclear sclerosis is very clearly visible in the this picture that you showed. And you could, whatever you want to do about higher order abrasions, etc., etc., if the patient is unhappy, I would do that. And you would also get a chance to also have any refractive surprise taken. I don't know which formula you use, because it doesn't then remain a post-LASIK cornea.
Right.
So a post-LASIK cornea has specific formulas which give you good outcome. You were lucky to get, because you have changed the topography significantly, right?
Right. So I used the Barrett True K, which is post-LASIK.
Yeah,
and
so
ray tracing.
post-LASIK is there, but then I haven't really, there must not be too many cases with a higher order abrasion correction and doing a lens power calculation. So this thing would be simple, clear cut, and also what Dr. Jagatram and Dr. Lahane said, yes, obviously, since the history of retinal detachment and indirect ophthalmoscopy pre and post surgery would be something to not get the patient onto that. But these patients do very well just with a simple cataract. That's what I would have done. But you got a good result, so that's fine. I would do a stepwise thing myself.
Thank you very much.